Vanakkam Chennai. Wishing you all a healthy and safe morning from the temple city of Madurai. I am Dr. Sundaravel, a maxillofacial surgeon, Associate Professor, Ultra Dental College, Madurai. I run my own private practice and also direct an academy with two more colleagues that trains fellow dentists in the field of implantology. Yes, the whole world is masked. Social life, day-to-day practice, learning, nothing is going to be the same again for quite some time. But humanity has faced greater challenges and we have always managed to come out on top. The night may be dark, but the dawn is soon coming. With these few words, I would like to thank Dr. Arun Suraj, CDE convener, and all the office bearers of IDA Chennai for giving me this opportunity to speak amongst the members of IDA Chennai. So, there are only two types of specialists in all of medical fraternity right now. One, the heroes on the front line taking the enemy head on. A big salute to them. And two, the hidden heroes who are staying at home updating their knowledge for the battle that's gonna begin next. I only pray the wait isn't too long. Hope I have your attention now. This slide truly shows the condition that I am in right now. Hope many in the audience may agree. Sitting, doing nothing has corrupted our brains and it did need a heavy charging for me to get ready for this presentation. Just to kickstart our thought process, we came up with this highly controversial topic. I have made this presentation as clinically oriented as possible and hope it will help you arrive at some definitive conclusions by the end of it. Grafting in implantology. We did not have clear protocols when we started our clinical practice 15 years ago. We were just embracing it back then and the cost involved was a huge deterrent. I believe it still is. Getting the science of implantology to be feasible in practice was my and many of my colleagues' first obstacle. Moving on in the learning curve, I came to know that the defective rehabilitation in a medically compromised individual is going to be the bulk of anybody's dental practice. I hope you will all agree with me. Being all energetic fresh surgeon, I try to correct all these defects by surgical augmentation. Convincing and treating such patients gives such a huge sense of satisfaction. But 2 years, 3 years, 5 years down the lane and observing from seniors, colleagues and teachers, I started realizing that patient satisfaction is the first priority. That makes this topic very special to me as it's going to be more or less my personal journey and experience in grafting for implantology. As a student, we were always taught that implantology is multidisciplinary, involving 3 branches at least. One being surgery, the second prosthetic and the third periodontology. But remember, it is always prosthetically driven. I see clinicians today who have knowledge about all the procedures like sinus lifts, bone grafting, alveolar distraction, ridge splitting, all on 4, zygoma implants, hybrids, soft tissue augmentation, etc. etc. Thanks to changes in the curriculum and thanks to the pan-India implantology courses, we attempt to train ourselves to be prepared for patients' demand and to enhance our practice. It's absolutely okay to do it from a clinician's perspective. So where do we start? As promised, I will make this presentation as clinical as possible. But just to get your orientation, I've added a few slides for some basics. In all the hype going around implantology, we shouldn't forget the basic principle for any reconstructive surgeries in medicine, which is to replace what is lost by what is lost. For example, if you lose bone, it has to be replaced by bone. If we lose skin, it has to be replaced by skin, and the same goes for muscle and mucosa as well. It applies to dentistry also. We got to replace a root for a root and a crown for a crown. That being theory, we would try to adopt as much of theory as possible when we practice. Putting it in perspective, the clinician's goal would be to attain the anatomy, physiology and function as close to nature as possible, as early as possible and as less invasive as possible, and the last and the most important point being as affordable as possible. Hope you will all agree with me. As you can see, the principles and goals are oxymoronic. So, to infer from these rules, we try to race them against time. The patient on the left was treated according to the principles, that is to restore bone for bone, tissue for tissue, and then the final prosthesis. And the patient on the right received treatment following the goals, that is to achieve anatomy, function, as less invasive as possible, as quick as possible, and as inexpensive as possible. And as you can see for yourself, at a given point of time, 3 months in case of above scenario, the patient on the right had had an implant placement, successful osseointegration in 3 months, and the final functional prosthetic delivered at the end of 90 to 100 days, and a very highly satisfied patient at the end of the day. Whereas the patient on the left was still waiting to receive implants and is not even halfway in the treatment process. Statistics and evidence prove that the number of surgeries, duration, pain, and cost are the primary factors that influence or deter the patient psychologically from accepting complex procedures in dentistry. So when you choose to augment bone surgically, it is going to increase the number of surgeries to achieve the goal. And of course, we have other possibilities and deterrents like donor site morbidity, possibility of infection, rejection, etc. Hence, we as clinicians are forced to deliver a foolproof treatment plan that's less invasive and less expensive, and the most important point, to be predictable. So when it comes to a clinical scenario, you can see some replacements in the ring graph. Success comes only when the expectation from the patient side is met by the clinician's expertise, and of course, economy comes to the forefront in an Indian scenario. Because we are not covered by third-party insurance like the Western countries. Whether this is fortunate or unfortunate, I really don't know. But the core point is, any treatment in the clinic can be successful only if the treatment plan is formulated with the patient's demand and expectations in the center. As far as expertise is concerned, you can either train yourself or you can hire an expert. Point is, the success is always patient-centric and is never clinician-centric. In other words, what I do is to formulate a treatment plan that's best for the patient, and if I feel I don't have the expertise to execute it, I'm never hesitant to call an expert. And I believe that's how it needs to be done if you want to avoid complications later on. I do understand that we might have a mixed crowd in the group. Expert in the group, kindly bear with me, and the beginners, I think this will be a good take-home point. Always remember the rule of 4 while placing implants. In short, during your surgical placement, kindly make sure the implant is 1 to 1.5 mm away from any anatomic structures. And wherever possible, try to place it 2 mm subcrustally. You should have a distance of at least 3 mm in between implants, and this will count for the prosthetic space later on. And last but not the least, you should have at least 4 mm of keratinized mucosa surrounding the implant neck. Anyways, I am not going to go into the finer details, as I strongly believe you must have definitely attended some form of webinar during this lockdown where all this was explained in a much more elaborate manner. Case selection hence shouldn't be a problem for you guys. So from a clinician's perspective, what do we expect? As shown in the picture, everyone loves to have ideal cases. We expect good volume of bone, good quality of bone, good oral hygiene, no comorbidities, good pain tolerance, acceptance towards possible complication, etc. But that ideal case is extremely rare. Hence, I've highlighted the highest priority in red, which is a big wallet, and hope the patient doesn't come back for the same complaint again. When it comes to the patient's perspective, you can see it's all red. He wants it to be painless, quick, the most advanced treatment as possible, and he always wants it to be lifelong without any complication, zero maintenance, and the most predictable treatment option, and it also needs to be cheap, etc. etc. It's really a Herculean task for the clinician. It's clear now that the circle isn't equal and various outcomes possible with the altered scenario. Considering option 1 where the red color, which is the patient expectation, if it's higher than the expertise and economy, beginners kindly keep away from such patients. It will be a real nightmare and you will wish the patient had never come to you on the first place. I believe all the senior implantologists out there will agree with me. In scenario 2, where the expertise is greater than the patient expectation and economy, you really wouldn't have as big a problem in hand. Maybe the clinician will feel he is being underpaid for this expertise, but I feel that's okay, as the patient is gonna go home with the feel of receiving more than what he had bargained for. I would term that a success, and in my personal experience, I've had such patients bring in more and more of referral cases. The third is what any clinician would really dream of having, which is a hefty economy which exceeds the patient's expectation and expertise. But as I said, it still remains a dream for many, and such scenario is highly uncommon. I would like to add a disclaimer here. The above statement is purely my own, coming out of my personal experience, and it's not intended to stir up any controversies. Now let's move on to the real life scenario. I've tried to cover all regions of the jaw to give you a fair idea. And to begin, let's start with the anterior maxilla. Being a maxillofacial surgeon, missing upper anteriors with defective alveolar ridge forms the major chunk of my implant restorative practice. This gentleman met with an RTA and in the process lost his upper anteriors. He had lip lacerations, comminutions of the anterior maxilla, dental alveolar segment, etc. And once they recover from the road traffic accident, they immediately want the missing teeth to be replaced for obvious reasons, aesthetics being the major concern. So this was his clinical presentation, and as you can see, there is an obvious loss of height in the anterior maxilla residual ridge. There was the defect of approximately 3 to 4 mm, and with the principles of reconstruction in mind, ridge augmentation with grafts was suggested prior to implant rehabilitation. The patient refused to take any grafting procedure, reason being the need for additional surgery both for augmentation and for donor site harvesting. The idea of artificial bone or bone substitutes also didn't go well with him, and the greatest deterrent being the time involved and the predictability. So we went ahead with placement of implant without augmentation procedure. As you can see from the post-op x-rays, we were pretty happy with the implant placement. And that's the result after delayed loading. The augmentation was done prosthetically, pink aesthetics as we would love to call it. Pretty happy with the labial support and arch form. Pink aesthetics wasn't so great, but we got away with it since patient had a low lip line. You must have heard many lectures on implant in the upper anteriors where the mentors would have spoken about the transition zone. And every word of what you heard is true. The rehabilitation at the transition zone poses the toughest challenge for any restorative dentist, and it can be a real challenging even for the most experienced dentist with high level of expertise. Fortunately, this particular patient didn't have the transition zone visible, and since we were able to produce a satisfactory result. Yes, I'm aware that this will start a lot of debate and many may have alternate treatment options. I don't contradict with you, and let me tell you, you are all right. But time, a restoration with good longevity and aesthetics were the top priority in this particular patient, and the treatment was planned accordingly. The take-home point here is to customize the treatment for each and every patient, and in the end, what really matters is to have a happy and satisfied patient. So good form, good aesthetics, good function, happy patient and a happy doctor at the end of the day. In our second case, I would like to show rehabilitation in the posterior maxilla. We all know that the atropic posterior maxilla can be augmented surgically by two methods, either by placing an only grafts or by sinus lifts. The sinus lifts may be direct or indirect. Again, these procedures have associated comorbidities, chances of getting rejected, infected, etc., and of course a lengthy treatment duration. I would like to thank Dr. Professor Sabarinathan for so kindly giving me these pictures. As you can see, this is a case where the posterior maxilla is atropic and the same was confirmed with radiographs. It was decided to do a sinus lift, grafting and placement of immediate implants. The aim was to minimize the number of surgical appointments, but in this particular case we had to abandon the sinus lift procedure midway and we chose to go with short implants. For definition's sake, short implants are any implants that have a length 8 mm and below. 3 implants were placed to rehabilitate the edentulous span 1-3 to 1-6. Implants were allowed to integrate for a period of 5 months and a symmetry retained PFM was delivered. You can see the post-op follow-up OPG, which shows good osseointegration and the prosthesis is doing well. There is more and more evidence in literature showing the predictability of short implants in rehabilitation of atrophic ridge over the use of sinus lifts or only grafting. The results we obtained were also correlating well with the literature. Technically though, we would have preferred a screw retained prosthesis considering the fact of ease of retrievability during maintenance. But the take home point in this would be that the atrophic ridge have very little bone and we may expect some unfavorable angulation that requires later on prosthetically to be corrected, and hence it would be a good practice to discuss the possible complication well before the treatment is executed. Coming to this patient, we did achieve good form, function and durable prosthesis with as minimal surgical intervention as possible. End of the day, we had a happy patient and a happy doctor. Coming to anterior mandible, it is considered the safest region for beginners to practice either grafting or placing implants, as we have good amount of quality bone and no vital structures. But the resorption pattern in this region can give a few headaches. This particular case, when we planned, we didn't expect any big challenges. Though it was atrophic and we had a vertical bone loss, since it was anterior mandible, it didn't pose much of a surgical challenge. We had good occlusal clearance, aesthetically less demanding, and hence we went ahead thinking that not much of great expertise was needed. But when the flap was raised, we had the true picture. It was a knife edge ridge. Now we had a morphology deficiency in both vertical and horizontal dimensions. So how did we go about this? Two choices. One, to abandon and revisit with a better plan. As a clinician, we would know this is the last thing one would want to happen in a dental office. No one would want to abandon what we started for fear of the loss of patient's trust. And option 2, yes, you people would have guessed it right, ridge splitting. These are situations where having a good surgical hand really helps. So we went ahead to split the ridge and place 3 implants to rehabilitate a span from 3.6 to 4.3. No grafting was done. End of 3 months, a cemented prosthesis was fabricated and delivered. Acceptable form and function was achieved in 3 months' time. Follow-up X-ray showed good integration and minimal crustal bone loss whatsoever. Possible prosthetic complication was discussed well in advance. So end of the day, peaceful sleep. There are 2 take-home pointers in this case. One, as already discussed, the unfavorable angulation in atrophic ridges, as we have very less bone to play around. Fortunately, we have a prosthetic solution for that problem. And number 2 is the deceiving picture of OPG and RVG. This particular case highlighted the need for CBCT in even the seemingly simple cases. It's an amazing tool which non-invasively gives loads of information regarding the bone availability 3-dimensionally and also good details about the bone quality. It's a boon in modern day implantology, and I wouldn't advise any one of you to plan an implant case without CBCT. It's a very affordable now, and there is no excuse to plan an implant case without having a CBCT in hand. Now for posterior mandible rehabilitation, this is one place which can be very tricky to handle. There are many surgical procedures like Cowrie's augmentation technique, only grafting, nerve reposition to augment this region prior to implant placement. But one needs to have a very high level of surgical training and expertise to do this. Highly impractical in a clinical scenario. The 2 anatomic limitations in this region are, as we all know, number 1 is the inferior alveolar nerve and number 2 is the submandibular fossa, as shown in the image on the lower right. It can at times be deep, encroaching on the mandibular space. It can only be picked by a CBCT preoperatively. So in all atrophic mandibular posterior regions, we can expect to encounter either the inferior alveolar nerve or the submandibular fossa. And the best way out is the use of short implants. As I said earlier, there are more scientific evidence coming in favor of short implants used for rehabilitation and is coming out to be an efficient, less complicated treatment alternative. In the case shown above, we had vertical loss of bone height and also a compromised buccolingual width at 3.6 region. So ridge splitting was done and 3.75 by 8 mm implant was placed. And that's the picture after rehabilitation at the end of 3 months. The concerns here would be the tall clinical crowns and the unfavorable implant to crown ratio in terms of size. But the fact here is, the implant here is ankylosed and hence the loss of crown root ratio and periodontal surface area in fixed prosthetic rehabilitation really doesn't seem to have applications here. Proof for it, I am glad to show these x-rays, 4 years follow-up. I was worried about the initial 1 mm crestal bone loss, and I hoped it was caused by the inflammatory response to surgery and not because of unfavorable prosthetic load transmission. Fortunately, in the following years, the resorption stopped. It's doing good so far, and I was fortunate to have this patient who is very regular on follow-ups, something which is very uncommon in our practice. Again, a happy ending to the story. Acceptable form and function at as less a time as possible and as less invasive as possible. Expectation satisfied, economy satisfied, and expertise satisfied. So we have a happy patient and a happy clinician. One more case of anterior maxilla. As you can see from the picture, a labiopalatally defective ridge is present. This is treated by ridge expansion and placement of implant. No grafting was done for this particular case. It was loaded at the end of 5 months. The case was done 5 years back. Acceptable aesthetics, form, function and lip support. A happy patient. Unfortunately, the patient was lost to follow-up. Now we are forced to believe that the patient isn't having any trouble with the treatment and hence isn't coming up for follow-ups. I'm sure you must also have faced such scenarios. And the last case for the day, again anterior maxilla. Traumatic loss of tooth. You can appreciate the labopalatal defect clinically as well as radiologically. Also, there is a remnant root stem present. Hence, we did anticipate bone defect after extraction and so plan to decide regarding the placement of immediate implant on the table. We had a discussion with the patient and he was explained about the possible need of grafting as well. He wasn't very keen on having grafts, the added cost being one of the major deterrent. We went into surgery with only one request from the patient, which is, "Doctor, please avoid grafts as much as possible." That's the intraoperative picture. As you can see, we had to remove some root stems and fortunately we were able to place immediate implants with good primary stability. And as expected, we got the jumping bone defect, which is actually the space between bone and the implant. I would have definitely wanted to graft the defect and maybe use PRP or PRF. We didn't do any of it because the patient didn't want to have it. My seniors and colleagues, when discussed about this case, told me I should have put better efforts and must have convinced the patient to accept for grafts. But anyways, it's more of the instinctive thing that grafting was not done. Fingers crossed, we closed the wound and discharged the patient. Post-op radiographs showed satisfactory implant positioning, but every time the patient called me thereafter, I did get chills before answering the phone calls. Maybe I was expecting him to raise some sort of complaint, but to our surprise, at the end of 5 months, we found excellent osseointegration and almost negligible crestal bone resorption. Crestal resorption is something which is supposed to happen in ungrafted alveolar socket defects. We have so many histologic studies to prove it. But the negligible bone loss here, if at all any, truly a miracle to watch how the nature heals itself without the requirement of additional treatment modalities like grafting or PRP. So, healing cap was placed, good keratinase mucosa was developed, impression was made, and the final prosthesis delivered. That was the final result. Excellent aesthetics, excellent form and excellent function achieved. A very satisfying result. Economy satisfied, expectation satisfied and expertise satisfied. So we have a very happy patient and a happy clinician. With these observations, I started to do some literature search and I did manage to find many such studies that support or have had similar findings. I thought it would be good to share some meta-analysis studies and some studies with randomized controlled trials. As you all know, meta-analysis and randomized controlled trials are the ones with highest level of scientific evidence. This particular study, published in the European Journals of Implantology, studied the rehabilitation of atrophic posterior mandible by short implants versus long implants versus vertical bone augmentation followed by placement of implants. I don't want to bother you with the details of the study, and hence I would like to go on to the conclusions. The results show the efficacy of short implants in atrophic jaw rehabilitation, and also went on to conclude that they are safer, cheaper, faster, and were associated with less morbidity when compared with other treatment modalities. This was one more study published in the European Journals of Oral Implantology, which studied the effectiveness of sinus lift procedures in atrophic posterior maxilla rehabilitation. They inferred that if the available bone height is 4 to 6 mm, use of short implants to rehabilitate without sinus lifting and without bone grafting was sufficient and successful. If the available bone height is less than 3 to 5 mm, indirect sinus lifts may be done with bone grafting and immediate implant placement was possible. But when the bone availability was 1 to 3 mm, direct sinus lift and bone grafting was advised, but a suggestion was made to delay the implant placement. It also went on to conclude that the need for sinus lift procedure was still unclear, number 1, and number 2, indirect sinus lifts with shorter implants gave a better outcome than direct sinus lifts with longer implants. And the last and most important finding, what I found to be the most interesting, is that this study questions the efficacy of PRP in improving graft outcomes. Now I know that's gonna open up a Pandora box and many would want to argue otherwise, but the evidence that I have seen so far is conflicting. This is one more meta-analysis published in the Clinicals of Oral Implantology Research, which studied the survival of short microsurface implant, and the conclusion that they say is the microsurface microimplants give a very predictable treatment outcome, and complication, if at all any, happen during the early surgical phases. So there was some strong evidence to the use of mini implants, thereby overcoming the need to do bone grafting in atrophic edges. Why is there a sudden surge in evidence favoring non-grafting methods and rehabilitation with microimplants? The answer lies in the biomedical engineering revolution that has happened in the past decade. Never has there been such close knowledge sharing and symbiotic relation between the medical field and the field of biotechnology and biomedical engineering. Let's stick to oral implantology. There has been extensive research in implant design, and hence we not only have improved macro structure but also drastically improved micro thread architecture. Macro implies the 4 basic thread designs in implants, which is triangle, square, buttress and reverse buttress. These macro designs that undergo surface treatment either by acid etching or sandblasting or by plasma spraying, thereby increasing the bone implant contact many folds. There is also the availability of surface activated implants in market now. These activated implant surfaces attract the cells required for osseointegration better than the normal surfaces. Also, changes in abutment designs, example the platform switch designs, allow better formation of keratinized mucosa around the implant neck, thereby producing a better biologic seal. The advent of multi-unit abutments have also changed our ideologies and knowledge about the stress distribution patterns during masticatory loading, thereby providing the possibility of redesigning our prosthesis, which in turn aids in overcoming the need for grafting. Yes, all on 4 concepts and zygomatic implants are what I mean and referring here. So, can we really ignore grafting? The answer is a big no. But can we avoid grafting? Yes, we definitely can. Being a maxillofacial surgeon, I wouldn't be doing justice to my specialty if I am not talking about surgical augmentation here. It will still remain a procedure which cannot be ignored fully. And in the above slide, I have highlighted the most commonly performed procedures. Starting with a traditional GBR, which means guided bone regeneration with bone substitutes and membranes. the traditional sinus lifts, the ridge expansion procedure, and the recently popular Cowries technique, where the cortical bone is harvested from the ramus of the mandible and fixed over the defect, thus forming a sandwich effect for filling the space in between with bone substitute materials. But even the most meticulously done grafting can have a success percent of only 50 to 60%, allowing about 40% of failure rate still in the best hands. A procedure with such a high level of unpredictability, I feel, cannot be a practical solution for clinicians. Hence, my suggestion would be to avoid surgical grafting wherever possible and go for alternates with better predictable rates. But definitely, one cannot completely ignore the grafting procedures. And what's the best possible way to make it work? Definitely not PRP or PRF or any kind of growth enhancers. I would recommend all the clinicians to stick to the basics, which is to have an infection-free recipient site, to develop good contact between the donor and recipient site and the graft materials, to have a rich recipient vascular bed, to have adequate immobilization of the graft material during the healing process, to have adequate soft tissue cover and a good tension-free closure. These are very important basics. And of course, the choice of graft materials. Different grafts have different success rates. Please kindly be well informed and do not believe what the graft supplier is telling you. And as you can see, for the overall success of grafting procedures, the choice of graft is only one of the criteria and not the only criteria. Enhancing with PRF, PRP, etc., I leave it to the viewer's discretion, as the scientific data available right now is highly contradictory. But keep in mind, the most well-done grafts can fail miserably. And to summarize and give you all a few take-home pointers, I would suggest you to avoid grafting wherever possible. And an implant without grafting can have a predictable success if it is planned only with a CBCT. And make sure the defect is enclosed on all three sides. The implant is placed with a primary stability of at least 35 Newton per centimeter squared. There are numerous scientific papers to prove that the implant fails if the primary stability is less than 20 Newtons per centimeter squared. The success rate is higher if the jumping distance, that is, the distance between implant and the cortical wall, does not exceed 2 mm. And it's always better to submerge the implant by 2 mm to account for the loss of bone that is going to happen when the socket remodels. PRP and PRF, though they have high claims, the evidence is still conflicting. And before we conclude, I would like to quote, "An young surgeon knows how to operate, an experienced surgeon knows when to operate, and it is the wise surgeon who knows when not to operate." So have your priorities right. Always derive a patient-centric treatment plan. You may take the opinion of many experts, but it should be you who finalize the treatment plan, and then evaluate if you have the necessary expertise to execute the same. If you feel you do not have the expertise, never hesitate to call someone who has the required skill level to execute your treatment plan. But never change the treatment plan to suit your expertise, and be bold with your decisions. Quoting from one of the many famous Talaivar dialogues, "Yosikama pesade, பேசுனதுக்கு அப்புறம் யோசிக்காத." Keep in mind, you are always the boss. Thank you for your very patient listening. I know that I have kicked a lot of controversies today, and I wish to take it further and have a healthy discussion with everyone. So please don't hesitate to post your questions, and I would be leaving my contact information at the end of the slide. This corona and the lockdown has taught the whole world the Tamil culture of Vanakkam. Proof that we already knew the importance of social distancing. So, Vanakkam Chennai, Vilithiru, Veetiliru, Coimbatore vittu vilagiru. என்ற தாரகை மந்திரத்துடன் வாய்ப்பு தந்தமைக்கு நன்றி கூறி வணக்கத்துடன் விடை பெறுகின்றேன். I am happy to share a couple of slides about our academy, where we have been training enthusiastic clinicians in the basic art of implantology, with our USP being to keep things as simple and cost effective as possible. And we have also structured the training in such a way that you can cover most of the important aspects in one day. Yes, you heard it right, in one day. We understand the busy schedule of our clinicians, and we did understand the obstacle of not being able to allot enough time when the training was happening in multiple modules, and hence we came up with this idea of completing the basics in one day. We are unique in allowing the participants to place implant on patients under mentor supervision as soon as the course begins, thus cutting short on boring presentations and focusing more on chat-side clinically oriented discussions, which we feel is more important for clinicians. I'm happy to share a few snapshots of our academy proceedings. Once again, I would like to thank the office bearers of IDA Chennai for giving me this opportunity, and a special thanks to my buddy and CD convener Dr. Arun Suraj for coming up with this innovative idea of WhatsApp in R to keep us all in the loop. Thank you one and all.